What's up, Ninja Nerds? In this video today, we're going to be talking about IV or intravenous fluids. Again, this is part of our clinical medicine section. If you guys like these videos, they make sense, they help you, please support us. You can do that a couple different ways. Hit the like button, comment down in the comment section, or subscribe. Also, for true benefit to really understand this topic, I have it linked down in the description box below. If you click on that, it goes to our website. On our website, we have really great notes, illustrations, quiz questions, case series, and so much more that you guys can check out and learn about this topic. Go check it out. All right, without further ado, let's really get into and talk about the physiology of IV fluids. All right, so we're gonna now move on to the physiology of IV fluids. There's actually two types. One is called crystalloids, and the other one is called colloids. Now, between these two, we'll talk about their physiology, but crystalloids are gonna be the more commonly utilized IV fluid for patients who are in the hospital. We use this a lot. Essentially, it's just, imagine I have a 1 liter bag of a solution, and that solution contains water, and then it contains some small solutes, things like sodium, chloride, and depending upon the type of solution, it may contain other things like dextrose or potassium, calcium, lactate, etc. But that's the concept. It's just basically a bag of water that contains small solutes. The amount of solutes that are present in that bag of water determines the osmolarity of the solution. The ability of those solutes to move water in certain directions determines the tonicity of that fluid, right? So it's the effective osmolarity. A lot of the times when we talk about crystalloids, we like to use that term tonicity. And so we have three different types. One is called a hypotonic fluid, isotonic fluid, and the other is hypertonic fluid. Hypotonic fluids, when you take a bag of the solution, and the two common ones that we often utilize are going to be what's called half normal saline, a very commonly utilized fluid, oftentimes as a maintenance fluid. We also use it a lot in hypernatremia, especially if they're a little bit hypovolemic. And another one is D5W. It's just dextrose and water. We commonly use that in hypernatremia as well. It's just we use it in patients who can't drink water, so they need IV water. We just can't give IV water on its own because it's very high risk of busting open red blood cells, and I'll talk about why in a second. So we give it with dextrose. So dextrose with water is actually isotonic, but when it gets taken into the body and the dextrose gets metabolized, all you're left with is water. And so that's the concept I want you to understand is hypotonic fluids. Usually when we talk about this, there is two components to it. One is water, and the other one is the solutes. Now there's gonna be a lot of water in all of these solutions, right? But the amount of solutes is what kind of determines the osmolarity. There's not very many solutes in this one. There's not a lot of sodium, there's not a lot of chloride in the normal saline, and there's some dextrose, but most of the dextrose gets metabolized and really all you're left with is water. So when you think about that, you have to think about the movement of water between a cell and an extracellular compartment. So an extracellular compartment is basically the blood vessel. This little space here called the interstitial space. This here is your ECF. And then the fluid inside of the cells is called your ICF. That's our basic cell physiology, right? When we talk about the movement of water via osmosis, it likes to go from areas of what? It generally likes to go to areas of low solute concentration where there's like less sodium to areas of where there's higher solute concentration or higher sodium. So here's what I want you to imagine. If I look at the solutes that are present in these cells, so let's pretend this is sodium or glucose or some other effective osmol that has the capacity to pull fluids in a direction, especially water, I'm gonna say the solutes in the cells is gonna be higher than the solutes that are present in the extracellular space, particularly the vascular space, because that's where we deliver this in. We give it to the patient's circulation. Where's the water going to want to move? The water is going to want to move here. And so it's going to leave the vascular space. And when it leaves the vascular space, a lot of that fluid, when it goes into the interstitial space, will go into our cells. Very little of this water and solution that we give to the patient stays in the vascular space. Very little of it. Most of it will go into the interstitial space, and most of it, pretty much all of it really, will go into the cells. And so when I talk about the significance of giving these fluids, I'm talking about really, I want to expand or increase my intracellular fluid volume. That's really all I'm doing, is I'm trying to hydrate the patient's cells, right? Now the risk of this, and here's the biggest concern. When we do this, cells can get too big. So the one thing that you never do is you never administer rapidly. The reason why is when you administer this stuff rapidly, it causes the cells to swell quickly because you fill them up. And if you fill them up, it can cause lysis of cells, especially red blood cells. So this can increase the risk of popping open cells, especially red blood cells. And so that's a really big point to remember, is you never give this fluid rapidly. You always give it in a slow infusion, usually as a maintenance fluid infusion. All right? So that's the big thing here. Hypotonic fluid, take this bag of half normal saline or D5W, compare it to my plasma. I'm gonna have less osmolarity, less solutes and more water than I would in my own plasma. Isotonic fluids, on the other hand, which are very commonly utilized in the hospital in the ICUs, is going to be your regular, good old 0.9% normal saline, or the other one that I love, it's my favorite, I'm gonna abbreviate it, lactated Ringer's lactate. This is a balanced solution, but they're both isotonic fluids, meaning if I take a bag of that fluid and I compare it to my plasma, the amount of solutes that are in the bag are pretty close to the amount of solutes that are in my plasma. So they're similar. So when I think about this, and when I give this fluid to the patient, it's going to contain water. It contains a good amount of water. But here's the thing I want you to think about. The amount of solutes that are present here in the actual serum, I'd say, are pretty close to the amount of solutes that you would find inside the cell. And so water doesn't really move in any direction if the amount of solute concentration is relatively the same. So let's say that I have lots of these solutes, but I have the same amount of solutes present here in the cell. There's going to be no net movement, right? No net movement. And so because of that, since there is no net movement into the cells, no net movement from the intracellular fluid. What do I mean? That means no fluid is leaving the cell, right? None of the fluid is coming out of the cell, going into the interstitial space and going into the vascular space. And no fluid is leaving the vascular space into the interstitial space and going into the intracellular fluid. There's no net movement. You're at a dynamic equilibrium, if you will. The significance of that is that most of this stays here in the extracellular space, but it can also move here. It can move a little bit between these two areas, but this is still staying in the extracellular space, because again, your extracellular space is your vascular space and your interstitial fluid, but no net movement is occurring from the intracellular space. So you're having no effect on the cell size. With that effect then, what we say is that this is going to increase the extracellular fluid volume, because we say most fluid stays in the extracellular fluid. And I'll talk about this because this is kind of important when we talk about this. When you give a fluid, your goal is to expand the vascular space. We usually give fluids to expand the vascular space or fix other electrolyte abnormalities, essentially. If I want to give a fluid that is not going to increase my vascular space, okay, then I'm probably, that I don't really want to do it, maybe I give this one. But if I want to expand my vascular space, I probably want to give this one. So that's the concept that you want to understand here. Now, hypertonic fluid, this is one that we only use in very select scenarios. I'd say the most common example of this is 3% saline. There is other hypertonic fluids, if you will. You can definitely take into consideration things like 8.4% sodium bicarbonate, which is usually given in codes or severe metabolic acidosis. But this is an example, I'd say, the most commonly utilized hypertonic fluid. Now, we take a bag of this fluid, compared to my plasma, way more solutes that are present in this solution than in my plasma. So that's the osmolarity of it, supraosmolar. This one, about isoosmolar. This one, it's hypoosmolar. This one, the tonicity effect is it's going to want to pull water into cells. This one, no net movement of water in or out of the cells. What do you think that was left with? We're going to pull water out of the cells. And the reason why is when you think about the components here, it definitely contains water, but boy, oh boy, does it contain a heavy amount of solutes like sodium and chloride. And so because of that, when you compare the solutes here in the plasma to the solutes here, let's say in this particular situation, we're going to say that you got some solutes, but it's nowhere near the amount here, right? So when you look at the solutes that are present in these cells, you have way more. Let's just give it another arrow. We'll give it even a triple arrow. Look at that. Triple arrow, baby. Way more solutes. Where's the water going to want to move? It's going to want to go out of the cells into the interstitial space, and then some of it go into the plasma, all right? So that's going to be the net movement, is water will want to go here. That's the net movement. And so because of that, it will be able to do what? Dehydrate my cells, right? And so that is a really important thing, is that when we think about the significance of this, this will do what to my extracellular space? It will increase the extracellular fluid volume. It definitely can try to pull fluid out into this space, but the more profound effect that it's going to have is it's going to dehydrate the heck out of these cells, right? And so that's a really important thing to remember, is it will decrease the intracellular fluid volume. The biggest concern with this is that when you give this drug, if you go too quickly, you can cause cells to undergo kind of like a shrinkage, if you will, right? And so we sometimes call that crenation. And so rapid administration or rapid increase in this fluid can increase the risk of shrinking the cells so much that they die. And we'll talk about that with this fluid. It's called osmotic demyelination syndrome. So when I talk about these again, these are the three basic groups of crystalloids. And I'd say out of all of these, the ones that is the most commonly utilized is your isotonic fluids because of their effect on the extracellular fluid volume. This one's good, but it's going to rehydrate your cells. Really good in patients who have hypernatremia, all right, or as a maintenance fluid. This one, it's good at shrinking cells, so it's good in patients who have cerebral edema. They have swelling in the brain, all right, or they need lots of solutes in certain scenarios like severe hyponatremia. The next one that I want to talk about is colloids. Now, colloids are great. I have always thought when you think about the physiology of them, it seems like they would be superior. And colloids are basically what we call plasma volume expanders. The most common, there is other ones like hetastarch, and I forget all the other ones. We don't really use those. The most commonly utilized colloid that I say that we utilize is called albumin. And it comes in different percentages, like 5% or 25%. But basically, it's a protein, right? And so essentially, let's say here, I draw here my albumin. So I'm going to give this albumin, this is my protein here, and what we know about albumin is albumin contains the ability to affect our osmotic pressure or our osmotic gradient. And so when I give a patient colloid, essentially what I'm doing is I'm really trying to increase my albumin. Now, the reason why that's important is albumin can help to pull fluid from the interstitial space, right? So again, extracellular space is this, right? But it's really good at pulling fluid out of the interstitial space into the vascular space. And that's very attractive when you think about that. That sounds really, really good. And so that's what it's going to want to do, is it's going to want to try to pull water from the interstitial fluid, right? From the interstitial fluid into the plasma. And so that's the goal of this. So albumin, what it does is it actually helps to basically increase your osmotic pressure. So it increases the osmotic or oncotic pressure in the vessel. And this helps to, as I said here, illustrated here, draws water into the vascular space. So when you think about this, it sounds like such an attractive fluid. And you'd say, oh, this one, if I draw a lot of that into my vascular space, boy, oh boy, will I expand my extracellular fluid volume, right? Especially the vascular space. And so the primary significance, and it can pull some of the water out of the cells too, but the primary effect is albumin's a big protein. So it doesn't usually leak out into the interstitial fluid, so it won't pull a ton of water out of the cells. It'll mainly just shift it from the interstitial space. But it will definitely help to expand the vascular space, which is a component of our extracellular fluid volume. And so it'll help to increase the effective circulating volume, right? Now, when we talk about albumin, one of the interesting things about this as a colloid is that we found no significant difference in efficacy between albumin and a similar fluid which helps to expand the extracellular fluid volume, such as isotonic crystalloids. And so that's really interesting. If anything, we find that these are really, really expensive. And the more common utilization of these, and we'll talk about it later, is actually more in decompensated cirrhosis. So patients who have very severe liver disease, who have hepatorenal syndrome, large volume paracentesis, spontaneous bacterial peritonitis, where they have very low albumin, and you're just trying to increase the albumin to maintain a good oncotic pressure. That's really where we've seen this being utilized. What I want to do before we go into each type of fluid and talk about their indications and complications and things to watch out for is I want to really kind of give you guys an overall view of why we give fluids. We're giving fluids oftentimes because a patient is hypovolemic. They're dehydrated, they're volume down, and we want to expand their volume. When we think about that, it's really important to think about what these fluids do to the vascular space, because you're trying to fill their blood vessels. When a patient's hypovolemic, they have less volume in their blood. That means they don't have a good perfusion. They don't have as much perfusion to their tissues, and organs can start to become, unfortunately, they can fail. And so we want to always know what's the best type of fluid to give to help to really save those organs or rescue those organs or support those organs. And that's where this concept, I think, comes into play. If I give a 1 liter bag of normal saline or LR, how much of that will actually stay in the vascular space of the extracellular fluid? And what we found is that with 1 liter, this will increase just the plasma or the vascular space by 250 mLs. So about 25%. When we talk about half normal saline though, that increases the plasma, not as much. It's about 100, and I don't expect you to memorize these. I just want you to get the point that not as much of this stays in the vascular space, so it's not a good resuscitation fluid. It's more of a good fluid for maintenance. And the last one here, or the second to last one, the D5W, look at how little of this stays in the plasma. Most of it goes into the cells, right? So most of this 750 goes into the what? The interstitial space. 167 stays inside of the plasma, and a lot of it goes into the interstitial space, and a lot of it goes into our cells. This one, it only increases the plasma by a measly, oh my gosh, look at this, by 83 mLs. This is not a good fluid to give to resuscitate a patient if you want to expand their vascular space, because most of it will go into the cells. Albumin is the one that when you hear this, you're like, oh wow, this is the best fluid. We just don't give it. But it increases the plasma by 450 mLs. By 450 mLs, especially if we gave the 25% albumin. So when you think about this, you'd say, oh, this one has a really good effect in fluid resuscitation. And then I would say this one. But we found that these two are about the same efficacy. We don't give these for fluid resuscitation. We give this more in hypernatremia or maintenance fluids, particularly this one as a maintenance fluid. These are more fluid resuscitation. This one can be used as a maintenance fluid as well. And we'll get into all of that. So let's now move on to talking about each individual fluid. All right, my friends, so with the crystalloids, we're gonna go through each one and talk a little bit more about them. But again, we know hypotonic fluids expand what? Intracellular space, a little bit of the extracellular space, because again, less solutes in the plasma, more of that water is going to want to go where? Into the cell. When we talk about these, there was again half normal saline and D5W. Now, half normal saline is a pretty commonly used maintenance fluid. Now, when we talk about this fluid, it's important to know what really makes it up, what makes up the solutes there. And really, when we look at this fluid, it contains 77 milliequivalents per liter of sodium and about the same of chloride. So 77 milliequivalents per liter of chloride. And then it contains a good chunk of water, probably about 95% of it is water. So when you look at this, that's going to be the components of what makes up this solution. A little bit of sodium, a little bit of chloride, definitely less than what we have in our normal body. All right. So when we talk about the sodium and the chloride, there's definitely less of that solute in this solution than there is within our blood plasma. And there's probably going to be more water in this. So what will we give this for? Well, it's not going to be replacing sodium and replacing chloride. It's probably going to be giving a patient a good amount of water primarily, right? That's really the primary indication. So when we talk about this, the primary reason why we would give this drug is going to be in a patient who has hypernatremia. So we give this in hypernatremia. Now, because this fluid does expand the extracellular space a little bit, it can be given in a patient who has hypovolemic hypernatremia. That may be a slight benefit to this fluid as compared to something like D5W, but it is going to be a great fluid in that particular scenario. Also, it is a very common maintenance fluid, and usually that maintenance fluid is in this particular scenario, but it can be used as a maintenance fluid. What do I mean by maintenance fluid? Let's say that a patient comes into the hospital because they have diarrhea, because they're vomiting, because they can't eat, right? They're NPO for surgery. In those particular scenarios, if a patient isn't taking in as much fluid as they're eliminating from their body, we have to supplement. We have to give them that fluid. And usually, half normal saline is a pretty good fluid to give to a patient when they are not having as much fluid intake as they have output. All right, so whenever the output is greater than the input, we supplement with half normal saline. Usually we mix it with D5, we add in some potassium as well to make sure that we hit all of these particular electrolytes and nutrients. So that's a very, very common scenario here, because when you think about this, we give this in patients who have hypernatremia because usually they're gonna have a very high amount of sodium. And so because they have high amounts of sodium, when you give them this solution, what you're really doing is you're giving them a ton of water. And by giving them a ton of water, what are you going to do? You're going to effectively bring down that sodium. All right? And so that's the benefit to giving this. Plus, you're also going to be expanding their intravascular space by about 167 mLs every 1 liter that you give. So it'll fill them up a little bit, and it'll also bring down their sodium and replace any losses. Now, the next thing that you have to know is whenever you give this fluid, there are complications. No thing that we give, especially fluids, comes without risk. And so when you give this fluid, let's imagine you have a patient, they have a normal sodium, right? Normal sodium, you start giving them this half normal saline. When you start doing that, what you may notice is that their sodium can potentially trend down, right? So you can potentially start noticing a decrease in the sodium. That's what I want to be careful of, because I can give it to a patient who has normal sodium or hypernatremia, but if I give them too much, so if I give too much of this fluid and I don't keep a close eye on it, I can have the patient develop hyponatremia. And that's the big complication. Why is hyponatremia so bad? Because there's less solute inside of our bloodstream. And then where would water want to go? If there's less sodium here, more sodium here, where's the water going to go? The water can easily flush into these cells. If the water flushes into these cells, it can cause cell swelling. And if you can cause cell swelling, the most prone area to this is the brain. And this can increase the risk for cerebral edema. I'd say that's a very, very concerning thing for a patient, is if you do this and they have any kind of intracranial disease, or if you do this and you drop their sodium too abruptly, you can cause swelling of the brain. So that's one of the big reasons why you have to be careful with these solutions. Also, you never bolus these solutions, because when you bolus these solutions, you potentially increase the risk of causing red blood cells to swell. So there is even a risk of hemolysis as well with bolusing these solutions. Don't ever bolus these usually. All right, next one is D5 water. Now D5 water is also a hypotonic fluid, and again, it's going to expand the intracellular space, a little bit of the extracellular space, but again, the benefit of this one is when you think about its components, it's really just like 50 grams of glucose. You give 50 grams of dextrose, and then it's just a bunch of water in the solution. All right, that's really it, it's just a bunch of water. And so when you think about that is the primary components here, the dextrose is going to get taken up and it can be utilized for a patient who's NPO. And so a couple different indications for this one is, again, it's usually going to be in hypernatremia. Most patients who have hypernatremia have what's called a free water deficit. In other words, they're not getting enough water because of maybe an altered mental status, maybe because they're intubated, maybe because they have no oral access and they have dysphagia and difficulty swallowing oral water. In those particular scenarios, maybe we have to give them IV water, but we can't just give them straight IV water. We have to usually give it with dextrose. And then once the dextrose gets metabolized, all you have left over is the water. And so the benefit is to give this in a patient who has high sodium, because if they originally start off with high sodium and you give them a lot of this water, basically, what that's going to do is it's going to dilute down that sodium. And so this is good at basically helping to decrease the sodium, as we talked about above. All right, so that's the benefit of giving this solution, is that you're going to give this to help to bring the sodium down in a patient who has hypernatremia. Usually this is given because we're trying to replace a free water deficit. So this is usually given to replace the free water deficit. Now, if I had to pick between which fluid I would give for hypernatremia, this is the more effective fluid to give, because you're giving them water and you're just giving them some dextrose because it has to come in that solution with it, all right, because of the risk of causing potential osmotic changes. It can cause hemolysis of red blood cells. All right, so we want to give this, all right? But again, this is going to be replacing their free water deficit if they can't take in oral water. This is a good one that you can give in patients with hypernatremia but are just a little bit hypovolemic, because remember, this one only expands the vascular space by 83 cc's. This one by 167 cc's. So you may fill up their fluid space, their vascular space, just a little bit more. That's the only argument, but again, I would pick this one over that one in this particular scenario. The complications are actually pretty straightforward. Again, you got to remember, a patient could have, in this particular scenario, let's say that they have a normal sodium, or they have a normal glucose level, right? So if they have a normal sodium, or they have a normal glucose level, and then you give them this D5W, maybe a little bit too much of it, all right? So you give them too much of this D5W, what could happen? Well, you can give them too much water, and then you could potentially drop down their sodium. All right, and so that's the biggest complication, is you can cause hyponatremia, right? And what do we say can happen with hyponatremia? Water can fill in these cells, and if you fill in the cells, what can happen? It can cause cerebral edema. So again, the biggest contributor here is the worry of cerebral edema. Now, the other thing is that you're giving glucose. When you give this, you give D5. And so because of that, you even increase the risk of giving them hyperglycemia. So you got to be careful. That's one of the things that you do want to be careful with this fluid, especially in a patient who has diabetes, is you can pump their glucose up a little bit too much and you can give them hyperglycemia. So that's the other thing, is just be a little bit more cognizant of this fluid in a patient who has underlying diabetes or hyperglycemia. You could worsen it. That's okay. You can give them insulin if you need to, but just be cognizant of their sodium levels. Hypotonic fluids, the big takeaway is oftentimes they're given to patients with hypernatremia, and what you're doing is you're trying to bring the sodium down, but if you give too much, you could overcorrect, drop their sodium, and give them cerebral edema. These don't fill the vascular space as much, they fill the cell, all right? Now that we know that, let's then go to the next fluid, which is our isotonic fluids. When we talk about our isotonic fluids, there's gonna be, again, our normal saline and then our lactated ringers. Normal saline is a very commonly utilized fluid, all right? Very, very commonly utilized. And we talked about this one. What do we say with the isotonic fluids? We say that the solute content is somewhat close. It's relatively close to our plasma, so it's about the same. So when we talk about the net movement of water between the extracellular space and the intracellular space, there really is no change. There's no net, the net movement, again, it's about equal, all right? So there's kind of a dynamic equilibrium, if you will. Most of the water stays in the vascular space or in the interstitial spaces. So it primarily is designed to fill the extracellular space. That's the physiology there, again, right? Because again, solutes are about similar between the cells and the plasma after we've given that solution. So it shouldn't cause a big change in the movement of water. There should be a normal net movement of water where it keeps the extracellular fluid space filled. When we talk about these, what makes them up? Well, normal saline, right? If we think about this one, all you're doing is doubling. You're just doubling it. So it was half normal, 77. So if this is the particular scenario, then we would have 154 milliequivalents per liter of sodium and chloride. And then you're gonna have some water. So whoa, that's a lot, right? What's our normal serum sodium? Usually 135 to 145. So you're definitely a little bit higher, but it's close. That's why we say it's like a somewhat isotonic. So in these particular scenarios, you're trying to give this when a patient has lost a lot of their vascular fluid. So for example, our primary indication of when we would give this is a patient who has hypovolemia, right? And is in need of what's called fluid resuscitation. And what I mean by that is I'm going to give this fluid pretty quickly. So we do what's called bolus therapy, and particularly with normal saline or lactated ringers. So if a patient's hypovolemic, we look at a couple different features, right? Dry mucous membranes, decreased skin turgor, hypotension, acute kidney injury. We look at a lot of those features, and sometimes even low sodium could be another feature here. But the hypovolemia could be because the patient's peeing out a lot of solution, right? And so they're not reabsorbing it, or they're having vomiting and diarrhea and they're not absorbing it. And so in these particular scenarios where there's going to be renal losses or extrarenal losses, you're losing those fluids. Another one is a patient could have blood loss. So if the patient is losing blood as well, that could also be another component. Either way, when you look at the fluids that you're losing, it's usually sodium, chloride, and water. All I'm going to do is replace their sodium, replace their chloride, and replace their water. So all I'm going to do is I'm going to give them back sodium, give them back chloride, and give them back water. And by doing that, I'm going to fill up their vascular space. That's all I'm really doing. I'm not reabsorbing sodium, chloride, and water. I'm not causing absorption of sodium, chloride, and water. I'm losing blood which contains sodium, chloride, and water. All I'm going to do is give them these fluids. And I'm going to replace their plasma components that control their volume. Do you see why it's kind of really cool? Because we're replacing somewhat of a similar solution, their plasma, with this normal saline. That's the concept. Now you can use this as a maintenance fluid. So for example, if a patient has ongoing renal losses, extrarenal losses, blood loss, you can use this as a maintenance fluid. And so that is a potential option. We'll talk about that when we get into our algorithm though. The big thing to know is when I give a patient normal saline, what are some potential complications? Well, one of them is actually really interesting. It can cause kind of a double whammy. We can see this in what's called a non-anion gap metabolic acidosis, and it can even cause hyperkalemia. Now, the concept behind this is actually quite interesting. When you give a patient normal saline, what you're really doing is you're giving them a lot of chloride, way more chloride than they're usually getting, right? Way more, all right? This is significantly higher amounts of chloride. So when you increase a patient's chloride, what you do is you actually decrease their bicarb levels, all right? So what you essentially do is you deplete their bicarb levels. And when you deplete their bicarb levels, you know what that does to your pH? It brings your pH down. And so this is why the patients get a metabolic acidosis, is it's called a hyperchloremic metabolic acidosis. Now, when you have a low pH, what happens to the protons that are present inside of your blood now? Well, I'm going to have less protons. If I have less protons here, now protons normally what happens is they do what, right? So if I have a lower pH, I'll have higher protons, I apologize, higher protons because it's more acidic. Protons want to move into the cells, and guess who likes to move out of the cells with them? Potassium. And so this is kind of like somewhat dependent upon one another. And so in patients who have a low pH, they have high amounts of protons. And those high amounts of protons stimulate these pumps. And when you stimulate these pumps, you pump out a lot of potassium. And so that is the big thing to remember, is that in patients who have heavy amounts of normal saline use, and they get hyperchloremia, that can cause an acidosis, drop their pH, and this acidosis can cause more shifting of potassium. So basically what will this do? This will increase the shifting of potassium. That's what's really interesting with this one. So we can see this with heavy amounts of normal saline use. Another complication that we can potentially see is hypernatremia. So you can see hypernatremia. And usually if you give a patient, this is pretty straightforward, if you're giving them heavy amounts. So this is with, I'd say, aggressive. We would see this with aggressive IV fluid use. If a patient is getting a couple different multiple boluses, staying on a maintenance fluid for a while, they can definitely get hypernatremia. All right, because all you're really doing is you're filling them up with a bunch of sodium and chloride. All right. The last thing with really kind of any isotonic fluid is you run the risk, if you give them too much, you do run the risk of what's called hypervolemia. All right. So this is usually, again, with aggressive IV fluid use. And oftentimes it can even be concomitant if a patient has underlying CHF. So if they also have, for example, plus or minus CHF or CKD, they're at risk for fluid retention, right? Even cirrhosis. And if you give them too much IV fluids, especially sodium and chloride and water, what are you doing? Well, if you give them lots of sodium and water, what are you doing to their blood volume? You're expanding their blood volume. If you expand their blood volume, what can happen is you can increase the osmotic pressures, right, in your vascular system. And when you increase the osmotic pressure, the hydrostatic pressures, when you increase the hydrostatic pressures, you can cause fluid to leak out into the alveoli, into the pleural space, into the legs, right? And so these patients are at high risk for pulmonary edema and pitting edema. And so it is really important to know, hey, I've given the patient way too much normal saline, because I can know, hey, they're getting hypernatremic, they're getting hyperchloremic with an acidosis, a hyperkalemia, and they're getting volume overloaded. I can see it when I listen to them. They have crackles and rales on auscultation. They're short of breath, right? Their chest x-ray shows pulmonary edema. Or their legs, like the Michelin Man, it's about 17 pounds in their legs, right? So that's kind of signs that the patient may have gotten a little bit volume overloaded because you gave them too much fluid. So that's really a really important thing to remember. So normal saline, good in fluid resuscitation, can be used in maintenance fluid, but we're primarily giving it as bolus therapy and hypovolemia. Big things to watch out for with especially a lot of usage of it is hyperchloremic metabolic acidosis, associated hyperkalemia, hypernatremia, and hypervolemia. Now, the next thing is lactated ringers. This is my favorite fluid. I love this fluid. It's a good balanced solution. When you talk about lactated ringers, again, same concept. It's going to be somewhat of a similar solution with respect to its osmolarity and its components as compared to our plasma. So again, there's going to be a normal net movement where there's not going to be as much movement in and out of our cells. It's primarily going to stay in the vascular space and the interstitial space. So it's going to fill up our extracellular fluid. This is going to be containing a lot of beautiful components. So it actually contains about 130. I wouldn't memorize this per se, I would just kind of understand it. This is closer. Now, if you think about it, it's a little bit lower than our serum sodium, which is usually 135 to 145. So if you think about it, it's like slightly hypotonic in that scenario, but it's a really good close number. We don't need to be giving heavy amounts of sodium all the time to patients who are hypovolemic. It contains about 109 milliequivalents per liter of chloride. That's way better than sodium, normal saline. That contains 154. This will have less risk of hyperchloremic metabolic acidosis and hyperkalemia. It also contains about 4 milliequivalents per liter of potassium. It contains about 2.7 milliequivalents per liter of calcium. And it contains about 28 milliequivalents, here's the name, of lactate. All right. Now, this is really what we're giving. And then on top of that, every solution contains water, right? Now, when we give these solutions to a patient, why are we giving this one? We're giving this one because, again, a patient is losing volume from their body. Usually this patient would be profoundly hypovolemic. So a patient would have hypovolemia, and they require what's called fluid resuscitation. When we give this fluid, why would I give this one over normal saline? Is there any particular indication? Not necessarily. I think it's a lot of the times it's clinical or provider preference. But in this scenario, it's the same thing. A patient's hypovolemic, so they're hypotensive, they have decreased skin turgor, they have dry mucous membranes, they have decreased urine output, so they have oliguria, they have flat veins, so they have no extended jugular venous pressure. And so because of this, their cause may be less reabsorption from the kidneys, less absorption from the GIT, and loss of skin losses. This is another additional one that sometimes we like to say on the boards. But again, similar scenario, they're having renal losses of sodium chloride in water. They're having extra renal losses of sodium chloride in water, right? And that could be from the GIT and the skin, especially burns. We like to give LR in burns, so I'll add that one on here. Burns is a very important one, and post-operatively or operatively, we prefer to give lactated ringers. It's referred to as the surgeon's fluid. They like to give it a lot in the OR. It's a great balanced solution, but again, you're giving it to a patient who is not having reabsorption because they're having lots of polyuria, vomiting, diarrhea, or they're having third-degree burns, significant burns. Because of that, they have a depletion in their plasma volume. You've depleted their plasma volume. What are you going to give them? I'm going to give them sodium, chloride, water, lactate, all of these things. And all I'm basically going to do is I'm going to pump up their sodium, pump up their water, and by doing that, I'm replacing their blood volume. So I'm replacing the lost plasma. Oh, another indication would be the same thing. If a patient also has blood loss. So you can even give this to a patient if they're experiencing blood loss. So with that being said, you're probably like, okay, lactated ringers, different composition, can give it in hypovolemia, fluid resuscitation, same thing like normal saline. Maybe in particular scenarios like burns, I may be a little bit more likely to give lactated ringers, or maybe as a patient who's in the OR. But really, what is the main reason I would give this fluid over normal saline? Well, the big one is I like to give this one if there is complications related to normal saline. So this one is better. It's better in NAGMA scenarios. So if a patient has a normal anion gap metabolic acidosis due to the hyperchloremia, I like this one better. If the patient has hyperkalemia, so it's better, even though there's all this thought, because most people get super scared. Oh man, if a patient has hyperkalemia, I can't give them this because I'm giving 4 milliequivalents of potassium. That's insane. 1 liter, 4 milliequivalents of potassium. Do you know how many, we give patients 40 milliequivalents of potassium a lot of the times in their, with like pills, right? You'd have to give, what? An insane amount. I'd have to give 4 liters. Right? I'd have to give a lot, actually. No, I'd have to give 10 liters. I'd have to give 10 liters of lactated ringers to give them the same amount of potassium as I would an oral potassium pill. So the likelihood of lactated ringers causing hyperkalemia is very low. Most often, patients who take normal saline in high amounts have experienced more incidents of hyperkalemia than lactated ringers. So this is a myth, and it's better in these particular situations as well, in NAGMA patients. Now, there is a potential complications, but they're very low and very unlikely. You can have a higher incidence of higher lactate levels, right? Oh, and then adding on here, lactate's beautiful. I love lactate. You wanna know why? Because lactate gets converted into bicarbonate. That's why there's also less evidence of normal anion gap metabolic acidosis. If a patient has acidosis, when you give lactate, lactate gets metabolized into bicarbonate. And so that's why one of the benefits of this is that you're not gonna have as much acidosis. All right, so that's pretty cool as well. But you can get high lactate levels in patients who have underlying severe liver disease. Lactate is supposed to be cleared by the liver. And so if you give a patient lactated ringers, you give them a little bit of lactate. That lactate should get taken up by the liver and get metabolized. But if it's not metabolized, then what ends up happening is that the lactate levels just build up a little bit. So you got to be careful of this in patients who have underlying liver disease. The other thing with this one is they have high risk of clotting whenever you give this with blood transfusion. So let's say that a patient's getting what's called a blood transfusion. When you give a blood transfusion, it contains a molecule called citrate. All right, it contains a molecule called citrate. And that citrate, all right, when given, can combine with the calcium. So there's about 2.7 milliequivalents of calcium within this solution. So if you give a patient calcium, giving them a little bit of calcium, these can combine. So they can actually chelate with one another. And what that can potentially do is it can actually increase the risk of clotting within inside of the actual IV lines or in the circulation. So it can increase the risk of clots. So they can experience some degree of incompatibility with blood transfusion. So you probably shouldn't give this to patients who are receiving active blood transfusions. Probably shouldn't give this to patients who have severe liver disease where they can't clear the lactate. The last particular scenario here is when you give too much of this fluid, they do run the risk of hypervolemia. So just like if a patient ended up getting normal saline, you do run the risk if they got aggressive fluid use. So if they received aggressive fluid use, so we gave like, I don't know, 5 liters of lactated ringers, you're gonna fill up their plasma, right? Because again, remember, normal saline, LR, for every 1 liter you give, you fill up the actual extracellular space, the vascular space by 250 mLs, right? So you fill that up pretty heavily. So because of that, you're going to increase their sodium, you're gonna increase their water, and therefore you're going to increase their blood volume. If I increase this patient's sodium and water retention, leading to an expansion in their blood volume, especially in patients who have fluid retention problems such as CHF or CKD, what's going to happen? You're going to increase the hydrostatic pressure, fluid is going to leak into their legs, and it's going to leak into their lungs, and you're going to get pulmonary edema, you're going to get pleural effusions, you're going to get pitting edema. So whenever you have a patient who's on lactated ringers, just keep an eye. Be careful giving this to patients with liver failure because you can get high levels of lactate if you're ordering these, especially if patients who are really, really sick and they're septic shock or they're hypovolemic and you're trending their lactate levels. If they have liver failure and you're like, why is their lactate levels persistently high? It could be because of this. Don't give it in patients who are also receiving concomitant blood transfusions, and then be careful, monitor, just as you would with normal saline. Is the patient developing any signs of volume overload or hypervolemia? Do they have jugular venous distension? Do they have weight gain? Do they have pulmonary edema? Do they have peripheral edema? All right. In those scenarios, you may have to stop the fluid resuscitation. All right. So that covers our isotonic fluids. The next component is, let's talk about hypertonic and then end off on colloids. All right, so we're off now to our hypertonic solutions. So these are solutions when you compare the plasma bag to the solution bag to our plasma, it's way more osmolar, right? So higher amounts of solutes like crazy, they're gonna have a tonicity effect where they're gonna wanna rip water from the cells. And so that's kind of advantageous in particular situations. So the components of this is just pretty much sodium chloride, like a normal saline solution, but then you're just taking it at a way higher amount. So now it's usually around 513 milliequivalents per liter of sodium. That's insane. And then about 513 milliequivalents per liter of chloride. And then obviously you're gonna have some water in that solution. So that's the primary components. And when you think about this, this is so significantly more than our sodium concentration in our plasma. It's significantly more solutes. So way, way hyperosmolar, and the tonicity effect is gonna rip water from the cells into the actual interstitial space and vascular space. So because of that, the indications is primarily in patients who have cerebral edema, or you give so much sodium that you can increase their sodium, right? So 2 indications for this, 2 beautiful indications, is going to be severe hyponatremia. So severe and symptomatic, I would like to add, because we don't just give this to every patient who has hyponatremia. So severe and symptomatic hyponatremia, which will represent like this. All right. So in other words, less than 120, it's acute, they're symptomatic. In other words, they're having headaches, they're having nausea, vomiting, they're having potentially elevated intracranial pressure. Or you're treating a patient who has cerebral edema. cerebral edema, right? Maybe they have a stroke for whatever reason. Maybe they have a large bleed. Maybe they have some type of like swelling within the brain where you need to reduce that swelling. This is a potential advantageous use of that drug. The concept here is that when I give this solution, what I'm really doing is I am massively expanding the sodium in the actual bloodstream. If I expand the sodium into the bloodstream, what I'm going to do is I'm going to yank water from the cells into the bloodstream. And that is going to reduce the edema. So that will reduce cerebral edema. It'll make more space inside of the skull. But on top of that, I'm also going to be doing what? I'm going to be increasing their sodium, right? So you give that high concentration, you're going to pump their sodium and also in the same time pull water from the cells, reducing the swelling inside of the actual skull and reducing intracranial pressure and edema in the brain. So that's the benefit. The complications is actually somewhat similar to a patient who gets normal saline. So in other words, you can still get the same concept. You can get that normal anion gap metabolic acidosis and the associated hyperkalemia. You can also get hypernatremia. That's pretty straightforward. I don't think that one takes a lot of understanding here, that if you give a patient this much sodium, you're going to increase their sodium within the bloodstream. And normally that's your goal, is to pump their sodium up enough to bring it up. And sometimes you overshoot, but sometimes you push it up high enough that you can reduce the cerebral edema. The NAGMA one, again, is because you're giving this patient lots of chloride. And so you're gonna drop their bicarb, and then you're gonna drop their pH. All right, so we remember this is that you're going to really increase their chloride, drop their bicarb, and drop their pH, right? And by doing that, what you essentially do is you increase the number of protons that you have inside of the bloodstream. And so more protons will flush into the cell, and more potassium ions will come out of the cell. Again, more protons will come in, more potassium will come out. And if you have this, you're going to get lots of potassium flushing out of our cells, which is going to induce hyperkalemia. So this is going to increase shifting of potassium. This is the scariest one. If you give hypertonic saline, 3%, you increase the risk of what's called osmotic demyelination syndrome. Pretty straightforward. You basically take a patient who, usually the risk factors for this is that you increase the sodium too quickly, right? It's way too rapid. So in other words, you go greater than or equal to 6 to 8 milliequivalents per liter in 24 hours. So if you increase the sodium greater than that in a 24-hour period, what you can potentially do is you can pull too much water out of the brain, all right? And when you pull too much water out of the brain, you can demyelinate some particular neurons. And so this does increase the risk of demyelination, particularly in the pons. And so now this area can become all jacked up, and you can increase the risk of causing multiple neurological deficits. And so this is going to be where the patient can develop things like dysarthria, maybe dysphagia. You can even alter their corticospinal tract, so they could even develop what else? They could develop quadriplegia. And sometimes you can even alter their eye movements. So you can even alter their eye movements where they don't have any horizontal eye movements. All they have is vertical eye movements. And so these are some potential things that you could see. So it can kind of present somewhat of a locked-in syndrome. So the biggest concern whenever you're giving 3% saline is when you give it too quickly. If you give it too quickly, or you give too much of it to the point where you rapidly increase their sodium, usually from a low sodium to a normal sodium. You can see it from a normal sodium to a high sodium. But whenever you give them a lot of hypertonic saline and you quickly push their sodium up, especially if they were hyponatremic to normal natremic, you increase the risk of demyelinating the neurons in the pons. and causing neurological deficits. Usually 2 weeks later, these presentation can start to occur. So that's the biggest thing. So 3% saline we give to these patients when we need to shrink the brain or increase the sodium because they're symptomatic. Complications is you can cause anagma, hyperkalemia, hypernatremia, and if you push the sodium up too quickly within a 24-hour period, you do risk demyelinating the pons and causing ODS. The last solution is that colloid that I was talking to you guys about. That's albumin, all right? Now albumin, it comes in 5% and 25% albumin. Usually, we give it the 25%, so it's just 25 grams of albumin. And it comes with a little bit of sodium in there too. Anywhere between, it depends upon the actual hospital, but 130 to 160 milliequivalents of sodium, and then it also comes with water. So these are the primary components of this solution. Now, the reason why you give this, we already talked about it a little bit. We'll give this to a patient who is hypovolemic. All right, so in other words, they're hypotensive, they have tachycardia, they have dry mucous membranes, they have decreased skin turgor, they have hypotension, they have oliguria due to reduced renal perfusion, etc. All of these signs. And again, we're doing this usually in an attempt to be very aggressive and get their fluid volume back up quickly. So we do it in what's called, again, as we talked about, I'm going to abbreviate this, fluid resuscitation. We're doing it quickly. We're giving these in boluses. When we do this, the whole concept is the same. You're doing it in a patient who has renal losses, GI losses, or they're having blood loss, all right? And because they're having renal loss or a GI loss of fluid or blood loss, all you're trying to do is do what? Give them albumin. The reason why is albumin, what's the benefit of this guy? If you guys remember, albumin will get over here into our circulation and it will do what? It'll pull water from our interstitial space and even a little bit from the intracellular space, but primarily interstitial space, into the vascular space. And so we're going to pull water into this vascular space to expand it. So basically what you're doing is you're expanding the plasma. You're expanding the plasma. And that's the benefit of this. Problem is as I told you, this is more expensive. And we found no difference in efficacy between giving albumin and giving normal saline. And potentially, there could even be higher incidence of mortality because it can cause things like hypersensitivity reactions. All right? What is really a true benefit, and we talk about this more in cirrhosis, is the best indications for albumin is really decompensated cirrhosis. So it's usually in cirrhosis-related complications. So we give this in HRS, SBP, people who get large volume paracentesis. That's the true indications because in these patients, they have a reduction in albumin production, and you're just trying to replace that albumin. So that's really where albumin comes in very handily. And so in patients who have hypovolemia, we can give them albumin. But if they have cirrhosis and they're experiencing hepatorenal syndrome, spontaneous bacterial peritonitis, they just had a large volume paracentesis, that would be a benefit to resuscitating them or giving them albumin. That's the true benefit. The complications that can be associated with albumin is that, again, you are trying to expand their vascular space. And because you are trying to expand their vascular space, sometimes you can fill it up a little bit too much. And so if you keep giving them heavy amounts, you're basically expanding their blood volume. When you expand their blood volume, you can potentially increase their hydrostatic pressure, and then that can cause fluid to leak out into the interstitial spaces, so it can leak into the legs, or it can leak into the alveoli, into the pleural space, and you can increase the risk of hypervolemia. So you definitely want to watch out for hypervolemia in these patients, especially if they're getting repeated doses of albumin. But a big complication is allergic reactions. I can't say that I have much data that shows this, but it is a concern because you're giving albumin. Albumin is a protein. When you give a protein, it could be viewed as a foreign molecule, an antigen. And so in these particular scenarios, it could activate our immune system, and our immune system could produce an immune response. And we could potentially generate antibodies. And so these patients do have a slight risk if you give them albumin of a kind of an immune reaction causing kind of like a anaphylactic shock. The biggest thing with this drug is it's extremely expensive. And so you just want to be kind of careful with giving this particular drug. So watch out for potentially allergic reactions. And again, watch out for hypervolemia when giving this. But albumin is relatively safe, and theoretically, when you think about the ability of it to expand the vascular space by 450 mLs, when you give a 25% albumin, it seems like such an amazing fluid. But again, what we found is, with giving fluid resuscitation in comparison to isotonic crystalloids like normal saline or LR, it's about the same efficacy. It's way more expensive. A better benefit to albumin is giving it in patients who have decompensated cirrhosis or cirrhosis-related complications. All right, my friends, that really covers all of our IV fluids. The next thing that we have to do now is say, okay, I have a patient, maybe they're hypovolemic, maybe they are hypernatremic, maybe they're hyponatremic. I need to give them these fluids, but I require vascular access. Which types of vascular access should I obtain to give this fluid to that patient? And then what we'll do is we'll take a real live patient and say, okay, let's say I have this patient, how do I approach this systematically in bolusing them, continue to bolus them, stop bolusing them? When do I do maintenance fluids? When do I stop maintenance fluids? Which type of fluid do I pick? We'll go through a whole algorithmic approach. So let's do that now. When we are going to give a IV fluid, we're trying to access their vascular system. Preferably, we want to access their venous system. And the way that we're going to access their venous system is usually a couple different ways. One is we're going to access it via a peripheral vein. So maybe one of the median cubital veins, maybe a basilic, a cephalic vein, etc. We're going to use a IV, access that vein, and then push the fluids through this venous structure. Through this apparatus here, right into their venous circulation. This is usually the first line. So it's the first thing that we want to obtain to give a patient IV fluids. If for whatever reason we fail to gain vascular access, we can try to use ultrasound. But if we really need vascular access right away, sometimes, especially in code scenarios, we will tap right into a bone, into that medullary cavity, which is filled with a lot of vessels, and we'll dump fluid into that scenario. So usually this is in a patient who comes into the emergency department. They've tried to get multiple peripheral IVs on the patient. They've tried ultrasound guided IVs. They can't get it and they need it, or the patient begins to code. We don't like to do central lines during codes if we don't have to, because you're sticking a needle around areas of vessels as the patient is undergoing compression. So this is the quick and easy way to obtain vascular access, is an intraosseous line. The other alternative is a central line. This is great when you have a little bit more time. So if a patient, maybe you've tried to get peripheral IVs on them and you just can't get it, this is a good one. You can access the jugular vein, you could access the subclavian vein, or you could even access the femoral vein. We like these whenever a patient has failed multiple peripheral IV attempts and we don't have an emergent need for an IO. But we need some central access here soon. Or we need to give them a large amounts of fluids. Now, this is somewhat of an older indication. It's not necessarily, they need lots of fluids, get a central line in. No. The benefit of putting in a central line is that it potentially can help us to monitor the central venous pressure, which has been shown in older kind of studies to maybe help us to know how much we actually should continue to give more and more fluids. All right. The next thing is that it's really good in patients who need vasopressors. So if a patient have severe hypotension, their blood pressure is really low, we've given them some fluids, and now we have to start putting them on a norepinephrine drip or a phenylephrine drip or epinephrine or whatever it may be, vasopressin, because their blood pressure is really low and they're on high concentrations. This is a good access site because it has less risk of venous sclerosis and irritation to the veins. The other indication is, yes, you could use it for monitoring of central venous pressure. It's not as an efficient of a mechanism. And the other component of this is that it actually can be used in drugs that have a lot of sclerotic effect, like hypertonic saline solutions. All right, my friends, so now what we're going to do is we're going to put everything together. We're going to talk about the approach to fluid administration. So in other words, I want to know which fluid should I give? All right, what's the rate I should give it? How long should I give it for? What should I be monitoring for in this process, etc.? And we're going to talk about a lot of these things. So first thing I need to know is what's the volume status of the patient. So do they appear that they have an enlarged jugular vein, all right? That could indicate that the central venous pressure is a little bit higher. Do they have any oliguria? That could be indicative of a low perfusion, but it also could be indicative in patients who have like CHF or right heart failure. Their central venous pressure is high and they congest the kidney and they can't allow blood to run through the kidney. So that could be one reason. Is their blood pressure high? Pulmonary edema and effusions is a really big one. So they have rales, crackles on auscultation, hypoxia, dyspnea, etc. Do they have peripheral edema? So is their legs really swollen when you push into it, leaves these big divots? Do they have any ascites? But more importantly, what's their weight like? Has their weight been trending up? If that's the case, this patient's hypervolemic. Don't give them any more fluids. Don't do that. If anything, you probably have to consider starting some diuretics for this patient, okay? So that's what I would say in this scenario. If the patient also does say, okay, they appear dry, so I see that they have a fissured tongue, their mucous membranes look really, really dry, they have decreased skin turgor, so you pinch and it still stays kind of tented up. On top of that, they have a very flat jugular vein or low central venous pressure. You can do this by looking at the jugular vein, but you can also use ultrasound and you can run it over the inferior vena cava and see if it collapses during respiration. You also see that they have oliguria. Maybe their heart rate's a little bit quick to compensate. Sometimes they can even have a little bit of orthostatic hypotension. The big question that you have to ask is the patient's blood pressure low? If the patient's blood pressure is low, this is a degree of hemodynamic instability and they need immediate fluid resuscitation quickly. All right, not a fluid challenge, we need to resuscitate them. All right. So we'll bolus either isotonic fluids or colloids. I find that isotonic fluids are just as effective as colloids and they run less risk of any complications and they're cheaper. So I'm going to bolus those, but you could bolus colloid. When you do this, depending upon if they have CHF or not, determines like the rate. I say if you have a CHF patient, don't give them a large chunk, right? Maybe 250 to 500 mLs, like over 15 to 30 minutes is appropriate. If a patient does not have CHF, you can go a little bit quicker and you can give a little bit more. I'd say around 500 mLs to about a liter over 15 to 30 minutes. Look to see what they do with that fluid. The whole goal is to improve their blood pressure, all right? Now, if a patient has hypovolemia, but they're not hemodynamically unstable, you then need to ask yourself, okay, how much fluid do I need to give them? And that's the tough thing to answer, right? If a patient's blood pressure is low, that's easy. You give them fluid if they look hypovolemic and you improve their blood pressure. But if their blood pressure is not low, how do you know if you should give it and how much more you should give? That's where a fluid challenge test comes in. And there's a couple different ways out there. There's so many different devices out there. But what we like to look at is the Frank-Starling's curve, right? And it looks at preload and stroke volume. And the whole point of this is that on the lowest part of the curve, this is a patient who is highly volume responsive. You give them fluid and they will benefit and their stroke volume will go up. As you get to the middle of the curve, they're a little bit less. As you get to the end here, any more fluid is not going to make any difference whatsoever. So we want to find these patients and give them fluid and see how they respond. So what you could do is you could give them a little bit of fluid, right? So one way is we can give them about 250 to 500 mLs of a isotonic fluid, normal saline LR, and then look, if you have a way of being able to monitor their stroke volume or monitor their cardiac output, look to see where they fall on that curve. If they show that they have a lot of variation in their stroke volume, then that might be a potential sign. If their cardiac output goes up, their stroke volume goes up, that might tell us, oh, okay, they're actually responding to this fluid. So you're looking for a fluid response or a non-response, all right? So you're trying to determine, does the patient respond to fluids and they do well, or do they not respond to fluids? Because that'll determine if you give them any more fluids whatsoever. So that's one way that I can give them a small bolus of fluid, 250, 500 mLs, hammer it into them pretty quickly, probably 15 minutes, and then look at the response to their stroke volume, their cardiac output, their blood pressure, their urine output, etc. But I'd say primarily have a parameter to monitor stroke volume or cardiac output. Another way that I like to do this in the ICU, because it's really cool and it's a teaching point, is I like to take patients and not give them any more fluid, but to use the fluid that they hold in their legs and their capacitance vessels. Funny enough, at any given moment, you can hold anywhere from about 250 to 500 mLs of fluid in your lower legs. That's about the same as an isotonic fluid bolus. So if I go ahead and I lift their legs, I'm going to rush this blood down into their heart, and I'm going to improve their end diastolic volume. And theoretically, if they're fluid responsive, I'm going to improve their stroke volume or their cardiac output. So what I would see is I would see an improvement in their cardiac output, and I would see an improvement in their stroke volume. Also, I would see a greater than 12% change. I would see that the stroke volume variation was intense. They had a great degree of change. That means that there was a significant improvement in their stroke volume. If there was less than 12%, there wasn't much change in their stroke volume, and therefore they didn't have much of a benefit. The other thing is you can potentially look for their blood pressure to go up and their heart rate to go down. I would say that this is not as great of a parameter, but it could be helpful. And I also like to look at urine output as well. Did their urine output go up with the fluid challenge? That could indicate a good response as well, because urine output is a parameter of cardiac output. So if the patient has any of these, you could say, hey, they responded well, and just keep bolusing them with fluids. Keep giving them fluids and seeing how they do. What I would say is just keep closely monitoring these parameters, because let's say I have a patient coming who's hypovolemic, their blood pressure is low. I give them about 1 liter of fluid. I do a fluid challenge test, which I do the passive leg raise, and see if they have any improvement. Oh, they do. They still have a good increase in stroke volume, cardiac output. Their stroke volume variation is still greater than 12%. The urine output improved with the fluid bolus, okay, or that passive leg raise. Give them another bolus. And so I might give them another 500 mLs or another liter and see how they do. But keep a close eye. So let's say that I did give them another 250, 500 mLs, or I did another passive leg raise, and I find that there is no change in their stroke volume or their cardiac output. At that point, I'm heading into this area of the curve. Me giving them fluid isn't going to make any bit of difference to their volume status. If anything, I run the risk of making them hypervolemic. If the patient has less than 12% change in their stroke volume variation, meaning I gave them fluid, I looked at their stroke volume prior, and then now there was no big change, that means that they're not really improving their stroke volume. And again, if there's no change in the urine output, I'm probably not making much of a big difference in the perfusion to their kidneys. At this point, you don't need to do any more fluid challenges. What you need to ask yourself the question of is, I don't need to bolus anymore. Do I need to do maintenance fluids? So that's when you ask yourself the question, does the patient have ongoing fluid losses? In other words, do they have things like polyuria, right? And diarrhea? And do they have maybe burns, or they're NPO and they're getting ready for surgery? If that's the case, then we may do maintenance fluids. If that's not the case and they're able to keep up with their intake as compared to their output, then we can just tell them to drink fluids and eat their food, and they'll be fine. But if they can't keep up with that, if in other words, if a patient is having diarrhea and they can't drink enough, or they're vomiting and they can't drink, or they are NPO and they aren't able to drink or eat anything, then we might have to help them. And that is when we will add on maintenance fluids. The maintenance fluid of choice depends upon the patient, right? And important to this is how much fluid do you give that patient of the type of fluid. So if I say, okay, have a patient come in, they're a hypovolemic, hypotensive, give them a fluid bolus. They actually make an improvement in their stroke volume, cardiac output. Great. All right, give them another fluid bolus. Oh, no change. Do they have ongoing losses? Yes. Okay, let's pick a fluid. Are we going to do normal saline, LR, half normal? Which one? And then which one I pick. Also, how much do I give them? What's the rate? So the way that we like to pick the maintenance rate depends upon if they're a pediatric patient or an adult patient. Pediatrics, we use what's called the Holiday-Seeger formula. So it's a 4-2-1 rule. So imagine we take a patient and we actually look at their weight, and we're going to do this. Watch this. This is actually kind of cool. You have a 25 kilogram patient. What you're going to do is you're going to take 4 milliliters per kilogram for the first 10 kilograms of this 25 kilogram patient. So now you're left with 15. Then you're going to do 2 milligrams per kilogram for that next 10 kilograms. So now you're left with 5 kilograms of weight left. So you do 1 milliliter per kilogram times 5. So that's 40 plus 20, and then plus 5. So what do we got? 65 milliliters per hour is about how much we're going to give them of this specific fluid, whether it's half normal, normal saline, or LR, to maintain an adequate intake that can hopefully equal their output. That's the goal. I love this formula for adults, which is a little bit easier, because all you got to do is take their weight in kilograms and add 40. So if I have a 70 kilogram patient, I just add 40, it's 110 mLs per hour. So that's about how much fluid of either NS, normal saline, LR, or half normal saline I'm going to give the patient to maintain an input equal to their output. So once I initiate this rate, I got to pick the fluid. If a patient has hyponatremia, especially hypovolemic hyponatremia, that might be a benefit to giving normal saline. All right. So watch out though, because if you give normal saline, you can push their chloride up. So watch out for NAGMA, watch out for hyperkalemia, and again, watch out for hypervolemia. All right. That's the big things to watch out for. The other one is if there's normonatremic. Which one did I tell you I love for normonatremia? It's one of my favorite fluids because it's a little bit more on the slightly hypotonic side and it's not as much risk of NAGMA and hyperkalemia. It's a great balanced fluid. That's where I would initiate LR. Just be careful for hypervolemia, all right? And the last one is if the patient's sodium is really low, right? I'm sorry, very high. If the sodium is very high, hypernatremia, then I want to give a hypotonic fluid that has more water that's going to dilute down the sodium and bring that sodium down, which is the preferred fluids. Half normal saline, right? You can also consider D5W as well. I like half normal saline as an alternative if the patient is hypovolemic. I like D5W if they're not hypovolemic and they're more euvolemic. But either way, I have an option there. The big thing to be careful of when you give these fluids is just to make sure that you don't push their sodium down too low. So watch out for hyponatremia. And again, high glucose, especially if you give them D5W. Again, what you're going to find is that most patients will kind of get a mixture of these two, where they'll get half normal saline. So most patients who will get a maintenance fluid, you're oftentimes going to hit them with half normal saline plus D5, and oftentimes you're throwing about 20 milliequivalents of potassium. All right. My friends, that covers fluids, our IV fluids. I really hope it made sense. I hope that you guys enjoyed it, and love you, thank you. And as always, until next time.